Thank you for being here still after a long day. And we start the last session on renal cancer. And with me, I have two colleagues, is the Nuno Val and Alejo Rodriguez Vida. And we will, chair this session. And the first speakers is Alejo Rodriguez Vida. He will discuss about new avenue in immunotherapy. Please. Then we will have clinical cases, which is always interesting.
Okay. Hello. First of all, I would like to thank the organizers for inviting me today, and also for you to wait. I know it's been a long day, so thank you for staying until the end. My name is Alejo Rodriguez Vida. I'm a medical oncologist from Hospital del Mar in Barcelona. And the purpose of my talk today is just to do a quick update on the state of the art of immunotherapy in renal cell carcinoma. Obviously, in 15-20 minutes, I don't have much time, so I will just focus on the most important studies. Obviously, the use of immunotherapy in the treatment of metastatic RCC is not new. Before the advent of TKIs, we would treat patients with interferon and IL-2. And then with the arrival of TKIs, we stopped using them. The arrival of antiangiogenic was like a kind of a first revolution or first change of paradigm. But now we are living a second one with the arrival of a new immunotherapy, such as such as PD-1 inhibitors and CTLA-4 inhibitors. Obviously, there is a lot of rationale for using immunotherapy agents in RCC. First of all, several spontaneous remissions in patients with metastatic RCC had been described in the literature, such as this case, which was a patient that had lung metastases, was treated with interferon for a couple of months, and then a lot of time after stopping the treatment, most of the metastases in the lung disappeared completely. Most of these complete remissions were assumed to be related to the immunology and due to the immune system. Also, we know that RCC exhibits a lot of immune infiltrates, such as monocytes and neutrophils, and also lymphocytes T, or T cells. We also know that there are a lot of immune escape mechanisms that have been reported in biopsies of patients with RCC, such as increase of Tregs, which we know are immunosuppressors, and also reduction in CD8 T cells and inhibition of the intratumoral differentiation of dendritic cells. So there are a lot of I think there's a huge rationale for testing these immunotherapy agents in RCC. Moreover, we also know that PD-L1 and PD-1 expression is very common in RCC. We know that up to 30% of tumor cells express PD-L1, and up to 50% of tumor-infiltrated lymphocytes express PD-1 or PD-L1 in biopsies or samples from nephrectomies. We also know that this expression, specifically the expression of PD-L1 in tumor cells, is related to more aggressive tumors, such as higher T stage, worse Fuhrman grade, and also poor survival. And similarly, we know that high PD-1 expression on TILs is associated with a shorter overall survival and a shorter metastasis-free survival in patients treated with radical nephrectomy. With all this background, when the first immune checkpoint inhibitors started to be developed in the last 10 years, kidney cancer was one of the tumors that was selected for testing these agents. As all of you know, immune checkpoints are markers that physiologically control the function of T cells and lymphocytes, and in order to increase their activity or inhibit their activity. The important thing about this is that several tumors, including RCC, have learned to overexpress some of these markers in order to evade the immune system. There are two major groups of immune checkpoints. The immune checkpoints that inhibit the function of the lymphocyte, such as PD-1 and CTLA-4, and others that stimulate the function of the T cell. Obviously, so far we only have approved drugs in this group of agents, but in the future we will probably have other drugs targeting the receptor agonist in order to stimulate the immune system. With this, as I was saying, the kidney cancer was one of the first tumors that was selected for testing these agents. As you can see, this is the phase 1 trial of nivolumab, which is a monoclonal antibody targeting the PD-1. This was an all tumors phase 1 trial, which included patients with melanoma, lung cancer, and RCC, also patients with prostate cancer. It is interesting to see that among all these solid tumors, patients with kidney cancer were the patients that achieved a larger response rate. As you can see here, 29% compared to 28% in melanoma or 18% in lung cancer. And we saw the first dramatic responses in some patients. As you can see here, this big mass reduced significantly after 6 months of treatment with nivolumab. After this phase 1 trial, a phase 2 was performed, and then a phase 3 trial, which I will explain very briefly, because I'm sure you all know. This was the first 3 trial of nivolumab compared to everolimus in second line in patients with metastatic RCC, previously treated with 1 or 2 lines of antiangiogenic therapy, the Checkmate 025 trial, which was published a couple of years ago in the New England Journal of Medicine. As we were saying, this was a trial for previously treated patients, and it randomized patients to receive either nivolumab or everolimus, which was a commonly used drug at the time as second or third line. The primary endpoint of the study was overall survival, and the secondary endpoints were objective response rate, PFS, quality of life. The study was positive for its main endpoint, which was overall survival. As you can see from the Kaplan-Meier curve, we see that from the beginning of the trial, the 2 curves start to split and separate significantly, and the nivolumab was associated with an improved overall survival, going from 19 months with everolimus to 25 with nivolumab, and these differences were statistically significant, with a hazard ratio 0.723, which means almost a reduction in the risk of death of almost 30%. The study was also positive for the endpoint of objective response rate. As you can see, 5 times bigger with nivolumab than with everolimus, 5% to 25%. This was also statistically significant. However, there were no differences in median PFS. Nivolumab, as you know, when it's given in monotherapy, it's a very well-tolerated drug. Most of the patients had a higher toxicity in the everolimus group than in the nivolumab group, when we look at the grade 3, grade 4 events. And the other side effects, most of them were grade 1 or grade 2, because grade 3 or grade 4, as you can see, were very, very infrequent. Another thing which is very important is quality of life. Obviously, we are talking about patients that are incurable, so it's very important that we try to improve their survival without causing them a lot of symptoms, a lot of deterioration in quality of life. And I think this is one of the highlights of the study, is that nivolumab is also associated with an improvement, as you can see, of the quality of life since the beginning, whereas with everolimus we see a worsening of the quality of life throughout most of the trial. Obviously, this is just one part of the picture. After the trial of nivolumab, the other immune checkpoint, which is very important, as you know, is CTLA-4. The interesting thing about CTLA-4 and PD-L1 is that both mechanisms function in a different place of the immune system. CTLA-4 is more related to the priming at a more initial position of the immune recognition, whereas PD-1 and PD-L1 are more important in a more final phase of the immune system, in a more effector phase. So both mechanisms are complementary and they are not redundant. That's why it's interesting to test a combination of the 2 drugs together. Obviously, the idea with this combination is to, thanks to the CTLA-4 agent, such as ipilimumab, is to achieve an activation, clonal activation of a lot of lymphocytes, and then thanks to the PD-1 inhibitor, just to focus this activity in the effector phase, attacking the tumor cells, which is what we actually want. There also has been a phase 1 trial, but I will just go straight to the phase 3 trial. As you know, this was presented as a plenary session in last ESMO 2017. It has been a really breakthrough study. This is the Checkmate 214, which was a phase 3 trial for patients that were treatment naive. It means that it's a first-line study. Patients were then randomized to receive standard treatment with first-line sunitinib or the combination of nivolumab, ipilimumab for 4 cycles and then maintenance nivolumab. And treatment was continued until progression or toxicity. It is important to highlight what were the endpoints. The primary endpoint was only for patients with poor risk or intermediate risk. And the secondary endpoint was for the intention to treat population, which means also including the good prognostic patients. And in both cases, they assessed overall survival, objective response, and PFS. These are the main characteristics of the study. As you can see, one thing that I think is important is that most patients were intermediate risk. As you can see, 61%. This is for the intention to treat, so it means all the patients included in the trial, which were around 1,100. And another thing that I think is important is that most patients were PD-L1 negative. Only around 25% in the whole group were considered PD-L1 positive, according to their cutoff. These are the results of the co-primary endpoint. Overall survival in the intermediate and poor risk. Very important differences we can see as you can see also that the graphs really start to separate very early, and we haven't actually reached the median overall survival in the nivo-ipi arm. But we see that the differences of the curves are statistically significant, and the hazard ratio is 0.63, which means really a reduction in the risk of death of almost 40%. So it's a positive study for the first endpoint. Moreover, the study also showed a significant improvement in response rate, going from 27 with sunitinib to 42 with nivo-ipi, and with a also very interesting 9% of complete responses in the nivo-ipi arm. Similarly, the differences in PFS were also statistically significant in favor of the combination. The secondary endpoint, as I was saying, was the same events, but in the whole population, also including the good prognostic patients. And as you can see, the differences in overall survival were also significant in favor of nivo-ipi, although the magnitude of the improvement was slightly smaller. Similarly, we see improvement in the overall response rate, but also the magnitude of the benefit was slightly smaller. But nevertheless, the differences were statistically significant in favor of nivo-ipi. However, we didn't see any differences in PFS, similarly to what we were saying about nivolumab in second line. This is something that I found very interesting, and obviously it's an exploratory endpoint, but then they also analyzed the effect of the combination in only the good prognostic patients, and it was very surprising to see that in this subgroup of patients, it seems like they benefit more from sunitinib, both in terms of objective response rate. It's not twice, but really significantly higher with sunitinib, and also in terms of PFS. We see that it goes from 15 to 25 months with sunitinib. I think this is very interesting because before the arrival of this study, usually we would tend to think that patients that had a slowly evolving disease were the ideal candidates for immunotherapy, whereas with patients with more aggressive disease, we would tend to say that maybe immunotherapy didn't act so quickly and it was better to use TKIs. But from this study, we actually have come to exactly the opposite conclusion. Nevertheless, it's obviously an exploratory endpoint, and the study is positive for the whole population. So that's something also to bear in mind. In terms of toxicity, I think nivo-ipi is slightly more toxic than nivo monotherapy, that's for sure, but I think that most of the side effects are manageable. We see that the grade 3/5 toxicity actually were more frequent with sunitinib, but treatment-related AEs leading to discontinuation was higher with nivo-ipi. So obviously there is some toxicity here. Nevertheless, the immune-mediated adverse events, which maybe are the most fearsome side effects that I think, as a doctor, you have to control. Most of them were grade 1, grade 2. As you can see, grade 3, grade 4 were very, very infrequent. And the most frequent ones were related to skin reactions and thyroid problems, which usually can be easily manageable. Similar to what we were saying with nivo monotherapy in second line, I think this is also very important. The trial has also demonstrated that nivo-EP is associated with an improvement in quality of life of patients compared to sunitinib. And these differences were also statistically significant. So I think that's also something that is important to bear in mind. After this study, obviously we are now waiting for the approval by the AMA, but hopefully we will be able to use nivo-EP soon, and in my opinion it will become very probably the new standard of care, at least for patients with intermediate and bad prognosis. What about PD-L1 expression as a biomarker? Here I put both studies side by side, the second-line nivolumab and the first-line nivo-EP, to say that there are a lot of conflicting data regarding PD-L1 in these studies, and it's difficult to really find a sense. In the second-line nivolumab trial, we only saw that PD-L1 expression was a prognostic marker, but not a predictive marker. Obviously, we know that overexpression of PD-L1 is associated with a poor survival, but we didn't see any marker of response, any role as a predictive marker. However, in the first-line trial with nivo-EP, we actually do see some predictive role of response. Obviously, we can see that PD-L1 positive patients in both groups, intermediate and risk and intention to treat, are the patients that benefit the most in terms of response rate. As you can see here, 58 versus 37 and 53 versus 36. Obviously, if you have a higher expression of PD-L1, you have a higher probability of responding to the combination, but that does not preclude PD-L1 negative patients from benefiting from the treatment. So I think that PD-L1 will not help us select patients, because patients with PD-L1 negative can also benefit from treatment. But obviously, if it is overexpressed, you have a high probability of benefiting from treatment. That's for sure, at least from this study. This is an update from the trial that was presented a couple of months ago at ASCO-SITC, and also comparing overall survival depending on PD-L1. And I think we see similar data in the sense that PD-L1 positive patients really have a greater benefit from the treatment, but the differences in PD-L1 negative patients are also statistically significant in favor of nivo-EP. So I think that also PD-L negative patients should also be treated with the combination. This is the subgroup analysis, which actually says pretty much the same. We see that for overall response, PFS and OS, for both groups, PD-L1 negative and positive, nivo-EP is always the better choice. This is a slide taken from the discussion from the plenary session, and I think it's very, I actually agree with what was said, is that nivo-EP is the first treatment to show an OS improvement in first line, and therefore it is a change of paradigm in the way we treat these patients. Actually, none of the first line trials with anti-angiogenic drugs showed any benefit of overall survival, so this is the first trial to do that. Moreover, it is the highest overall response rate ever reported in the trial of first line, the longest duration of response, and the highest complete response rate seen to date in a first line trial. So obviously this is a really breakthrough combination, in my opinion. Obviously this is just one side of the picture, but I think that the future, part of the future, is going to come from the combinations with IO and TKIs. Is there a rationale for that? Actually, yes, there is. We know that VEGF physiologically acts as immunosuppressor, and that if we combine TKIs with anti-PD-1, we might be able to enhance the efficacy of the IOs by reducing the immunosuppression that myeloid-derived cells are able to produce by secreting VEGF. Actually, we know that by combining those treatments, we might be able to promote T-cell priming and activation, and also normalize the vasculature and increase the infiltration by T-cells, and also be able to decrease the levels of myeloid-derived cells and Tregs, which are these immunosuppressive cells that produce VEGF. Yeah.
2 minutes.
Yeah, I'm finishing. It's really difficult to do that in 15 minutes. So just to mention very briefly some of the combination trials, the nivolumab and sunitinib phase 1 trial. Obviously, it's a small trial. We still have to wait for the definitive results, but we are seeing some amazing results, as we can see here, 50% of objective response rate, a duration of response of over a year, and very, very few patients that progress as a first response. And obviously, the first phase 3 trial combining a TKI with an TKI with an IO therapy, which is the atezo-bev trial that was presented a couple of weeks ago at ASCO GU. This is a similar trial to the Nivo-Ipi one, in the sense that it's for treatment-naive patients, and they are randomized to receive standard treatment with sunitinib or atezo plus bevacizumab, atezolizumab as a IO and bevacizumab as an anti-angiogenic drug. The study is positive for the co-primary endpoint of progression-free survival in the PD-L1 positive patients, and also in the intention to treat patients, including both positive and negative. However, we do not have data of overall survival. It was negative or not mature enough. So obviously, I think that in that sense, we will have to wait longer until we have overall survival data in order to really do a comparison with the Nivo-Ipi trial. The objective response rate was also significantly higher with the combination than with sunitinib in both treatment arms, and the toxicity profile of atezo-bev looks to be very, very promising in comparison to sunitinib. And that's my slide, sorry. I think immunotherapy in renal cancer is here to stay. Nivolumab is the first agent to show an overall survival benefit in second line, and I think it's one of the new standard of cares in second line, along with cabozantinib. Nivo-Ipi is the first drug to really overcome sunitinib in a randomized phase 3 trial in terms of overall survival, and I think it's now one also of the new standard of care drugs, especially for intermediate and high-risk patients. PD-L1 does not guide treatment selection. I think it's interesting to assess it, and if it's up, it might mean that you might respond, but if it's negative, it does not preclude you from benefiting from treatment. Obviously, we need more predictive biomarkers. I didn't go in details in that because obviously I didn't have enough time. And obviously, I think that the combinations of TKIs and IOs are very, very promising. There are a lot of other studies combining pembrolizumab, nivolumab with axitinib and other TKIs, but obviously we'll have to wait for the results. And I think that the toxicity can also be an issue in some cases. And that's it. Thank you.
Thank you very much. So you made it. Good. Question from the floor. Yes, please. State your name and institution, please. And first, second, then we have others. Let's see.
Good afternoon. My name is Elder Mazinha. I'm from Hospital Garcia de Horta. And I would like to ask this. Well, the data from Checkmate 214 are good, the results in poor risk and in intermediate risk patients, but the toxicity is really an issue. And I would like to ask you, what are really the patients that we consider for this association in first line?
Well, I think that toxicity, in my opinion, is not really an issue if you know what can happen and if you know how to monitor those patients and how to follow them very closely, especially at the beginning. I think that other than the immune-related toxicity, the other side effects are really, really usually very mild. And maybe the most fearsome side effects, which are the potentially severe immune-related side effects, if you follow the patients quickly and you know how to treat them, I think usually you can manage them quite successfully. Obviously, you need to be aware of this and you need to know how to treat them. But I think we have also learned a lot from the first trials in melanoma, when some patients died of colitis. Now it's very, very infrequent that a patient dies from a colitis from Nivo-Ipi or from ipilimumab in any case. And I think that that's because we have learned a lot since these drugs were started in the melanoma clinics. So, and that's something that when you speak with the melanoma doctors, they tell you, well, 5 years ago we didn't know how to manage these side effects, but now that they have learned and they have more experience, I think it's less of a problem. And I think it will happen the same with these agents in RCC. Personally, I haven't used this combination, but I have used the combination with tremelimumab and durvalumab, which is a similar combination, and I have had very, very, very few side effects. So usually it's quite easy.
Short answer,
Yeah,
short
sorry.
question. Otherwise, it's a presentation. Okay, the second one.
So thank you so much for your presentation. My name is André Mancin. I'm from Hospital Santa Maria. I would like to ask, recently FDA approved cabozantinib for first line with the phase 2 trial of the CABOSUN. So in the 214 trial, we know that despite they benefit from the patients that are PD-L1 negative or inferior to 1% benefit from the combination, they benefit very little. And probably intermediate and poor risk patients reflect a biological rationale that we don't still know. So in those patients with the two alternatives available, would you consider sequencing cabo and nivolumab or doing nivo-EP upfront?
You mean for patients who are PD-L1 negative,
but poor intermediate, yes, poor intermediate risk.
Poor intermediate. Personally, I think I would rather start with nivo-EP initially, and if you do a close follow-up and if you don't see a response, then you can switch to anti-angiogenic therapy. But the benefit was really seen across all the subgroups, not only the PD-L positive patients. So I think that especially the intermediate and the poor risk patients are the patients that benefit the most. So I would personally maybe start with nivo-EP.
Okay, other questions? So I just coming back to a very practical point. I mean, we are urologists. You know, you showed us a lot of data, a lot of concepts. However, you know, we are waiting for neoadjuvant therapy. Neoadjuvant, yeah. Mm-hmm. Are we ready to do it? Just a trial. Listen, this I have in mind. Trial neoadjuvant with this.
Most
nivo plus.
Most trials are testing these drugs in the adjuvant setting, in the neoadjuvant as well. But
I know that. Since the first line is working, this combination, what do you think? Just radical nephrectomy versus neoadjuvant plus radical?
I personally would rather go for the adjuvant setting of the drugs rather than the neoadjuvant setting because, I think it's better.
And I make another question. Just in patient with extended disease to cava, vena cava, do you have any data on reduction of the thrombus after this therapy?
No, there is no data.
This could be helpful very much for urologists.
Absolutely. But the thing is that neoadjuvant trials are much more difficult to really perform. That's something that
I had only one case who responded. Okay, now we go on with the case, the clinical case. Stay here. And I called the two speakers before. Can come to the podium because you're gonna be the discussion panel. And I give the podium to Nuno Val for the case presentation. Please make it interactive. Don't go on with your case.
Well, I will when you want to stop me.
Yes,
probably
ask
the
question.
best way.
Ask question. Okay.
Okay.
Good.
Okay, I'll try.
Otherwise, I will ask.
I'll try my best. Okay. Good afternoon, all. Thank you, Dr. Calais, for inviting me. I will present a clinical case which probably bring us some insight in some topics that we have taught. Well, it's a female, 60-year-old female. He has an important past medical history, not very important, but she had hypertension, asthma, food allergy, which turned out to be important in the future. And she has no family history of oncological diseases in terms of medication, nothing very strange. In August 2014, she noticed fatigue and weight loss, which are very unspecific, so she didn't really look after it. And in October, an abdominal ultrasound showed a left kidney mass. And this was confirmed by MRI, which confirmed the suspicious left kidney lesion. In December 2014, she was submitted to surgery, laparoscopic left nephrectomy, radical, and histology showed clear cell renal cell carcinoma with sarcomatoid differentiation. and it invaded the perirenal fat. Invaded the perirenal fat. We discussed this case in the multidisciplinary team, and we considered that there was no indication for adjuvant therapy.
I have a question for you. What's the reason why you waited 2 months for the operation?
You should ask that for the patient, because she only arrived at our clinic in late November. So
Okay.
I don't know. In March 2015, she was asymptomatic and the CT scan showed no sign of disease. In June 2015, she continued to be asymptomatic, but we performed the CT scan without IV contrast due to the atopic problems, and it showed de novo mediastinal adenopathy and the right adrenal nodule and the right kidney complex cysts. We discussed this case, and since we could not use, or we should not use, IV contrast, we decided to continue follow-up in the future with PET-CT using FDG. And at this point, the suspicious adenopathy had some uptake, not very big, but some uptake, and the right adrenal nodule did not have any uptake, and there was some uptake in the kidney lesion.
Yes, wait a minute. Now we have the expert here. What would you do? You are Andre?
Yes.
Okay. What you do in this case? Don't look at the MDT. They say systemic treatment, but we don't care about. You are the leader. What you decided this point in this lady?
So at this point, probably with this volume of disease and this uptake, I'll probably initiate therapy with TKI. So yeah.
How about you? The same?
Yeah, I agree with that. The question is if you should start with sunitinib or pazopanib, I think.
This is the question.
Yeah.
Tell us.
What one?
Yes, which one?
Well, we use usually sunitinib because we are...
First
Yeah.
line sunitinib.
Yeah.
You agree on that? Any comment on the floor from the floor? Yes, please.
Wouldn't you consider doing a biopsy since there was such presence of sarcomatoid histology in the initial?
So you asked for biopsy.
Just to confirm that this is mostly clear cell.
Say it again because nobody can hear you.
So since the initial tumor had a presence of sarcomatoid differentiation, although we don't have the percentage of it, but since it had, we don't know which part of it is the one that is mostly here suspicious of metastasization. So I think it could make a difference in deciding the systemic treatment, I think.
Okay, good. I will add a surgical question. How about lymphadenectomy in these patients? You didn't take care of lymph nodes because the literature said you don't do it and so on. But 3% of people may have a good response from that. But go on.
Okay. We didn't consider the biopsy because we thought that it wouldn't change really the therapeutic options. So we decided for systemic therapy, and this is the images that I talked to you previously. And we started with sunitinib, and we started with 50 milligrams, 2 weeks on, 1 week off. And we had some toxicity, expected toxicity, but we had some toxicity. We had to adjust the anti-hypertensive drugs. And things continued. In September, the toxicity was getting very heavy for the patient, so we decided to decrease the dose. We had to start levothyroxine.
Excuse me, do you agree on that? You will decrease the dose?
Yeah, I usually started with sunitinib and 2 weeks on, 1 week off. But there are some questions about this strategy because we don't know really if in the retrospective data, if the worst patients won't stop before we change, not in first line, but in second line, for example. And there are some questions, but they are really in terms of adverse events, it's better tolerated.
Okay. Any other comments, questions? Okay. Go. Okay, yeah, question.
And why not another kind of chemotherapy, not sunitinib, because it's a sarcomatoid?
Okay. You would that change the drug?
The first line, not sunitinib, but
This was 2015, you have to remember. Okay. Go on.
So we had to make another adjustment in terms of the antihypertensive treatment, and this was getting very heavy. And in December, we were considering decreasing the dose once again because the patient wasn't very comfortable. And we repeated the PET, and we found de novo 2 new lung lesions. The rest of the disease was almost the same. We discussed the case. We assumed progressive disease. We stopped sunitinib and started second line with nivolumab.
Okay, do you agree on that? Andre?
Yes. In this case, this is a sarcomatoid patient. For first line, the only therapy that we think or we have prospective data is sunitinib, so yes. On the second line, additionally, nivolumab was also going to be my best choice. So.
Okay, and you? What do you think?
Yeah, absolutely. Alternatively, cabozantinib can also be considered for second line. But, and especially now that we are seeing that most aggressive patients benefit more from immunotherapy, maybe nivolumab is the best choice.
So they say you did right.
Yeah.
Okay.
Thank you. Thank you.
Yeah, of course.
That comes to the question of the biopsy that you asked. We are all assuming that this is the sarcomatoid portion,
Yeah.
but we don't know.
You're right. This is good.
This is a part of the
Good
problem.
comment. Yeah, I think so. What our colleagues said before is perfectly fit in what you say. I mean, it's not. I mean, we don't know which kind of tumor it progressed, if sarcomatoid or just the renal cell. I
You
mean,
will know in the future.
we will know it.
You will know.
Okay.
I have the answer for that. At this point in time, I didn't.
Okay, go.
So she continued nivolumab, which was better tolerated, just minor toxicity. And a few months later, 3 months later, we repeated the PET FDG, and the lung lesions had disappeared, and the rest of disease was almost the same. In June 2016, we continued the same strategy, nivolumab with the same very good tolerance, and the PET-CT was the same. So far, so good.
How about the quality of life of the lady?
Very good.
Is it good?
Very good.
Enjoy life. Good.
Yeah. Pissing her husband at this time. Because she was feeling with a lot more energy. So in November 16, things were the same as well. In January 17, we had the first problem. She appeared with the night. During the night, she had the onset of precordial crushing sensation, palpitation, no dyspnea, and she brought from the emergency department in the hospital near her house a very troubling SCG with an ST depression.
Just a second. What do you think right now? What do you think to do? Difficult.
Well, sorry. I think you have to do a general checkup, but cardiac toxicity are very rare with these agents. I mean, some cases of myositis have been described, but they are really infrequent. So I would maybe think that maybe she's progressing in the chest, other than really having cardiac toxicity.
Let's ask our colleagues here. What would you think?
In this case, of course, myocarditis is relatively rare because it happens mainly with combination therapy. Monotherapy, we haven't seen that side effect. So myositis could be an option, but the troponin is negative and the CKMB is negative, so it's more likely progression than something related to the cardiac disease. I don't see anything else.
Do you agree on that?
Yeah, it was. It's absolutely demandable that we could exclude cardiac toxicity, but they have done all the things that they should. With an echo, enzymes were negative, EEG was okay.
Also, I think maybe a lung embolism should have to be ruled out as well.
Okay. Any other ideas from the floor? Comment? No. What happened?
What happened is we consider that it was not toxicity. There are some variants, I'm far from cardiology, but there are some variants of namely Prince metal angina that can give this kind of pain without having any problems in the angiography. And so we decided not to assume this as cardiac toxicity. We didn't start cortical therapy, and we resumed about 1 week. With 1 week delay, we resumed nivolumab. In May, everything was going okay. She didn't repeat these episodes of pain, and the PET-CT showed something different at this point. It was the mediastinal lymph node was the same, but we had the lesion on the adrenal was increasing. So although it did not have any uptake with FDG, it was increasing in size. So at this point, we made an MRI, and the MRI gave us a bad news. It was 3 suspicious nodules, and they had characteristics in the MRI that make them very suspicious, and give us a darker picture of the cystic lesion in the kidney. And we decided in the MDT to go for focal treatment. We first asked the radiotherapists if they could do ablative therapy. The lesion was close to the duodenum, so they told us that it could
Which kind of focal treatment you decided?
Radiotherapy. The first thing that we tried was radiotherapy. And they considered they wouldn't be ablative because the lesion was very close to other structures. So in order to destroy this lesion, they would probably give the patient some problems. So we decided for surgery. And the surgery was performed in September. She made laparoscopic adrenalectomy.
Excuse me, do you agree on this policy, or you would have done something different, please?
No, at this point, my question is, did you consider that the patient was progressing? And if she was progressing, what's the rationale, and why did you choose to continue nivo after the stereotactic?
Because she was progressing just in one side. The rest of the disease was controlled, as far as we knew.
In the lung, you mean?
In the lung was, and there is no new lesions. And the patient was asymptomatic. She was doing her normal life. So we considered it would be more logical to go after, to treat
Let's ask the audience. Who would have done the same here? Raise your hand. Okay, who would have not? What you?
This case is a little bit confusing because a patient had left radical nephrectomy, had met the mediastinum eventually, and they eventually developed something in the right kidney which was never defined. Is that the case?
It was present from the beginning, but in the first MRI,
so
it was
she may have a second tumor. This is
Probably,
a
yes.
Bosniak 4.
Yeah, probably
and,
she has a
and
second
second, clearly there is a lesion in the adrenal that, in my view, anatomically, the duodenum is very far from the adrenal on the right side, believe me, at least for cryotherapy.
Okay.
So it's confusing because we don't know exactly what we're treating.
Yeah. Yes. State your name and institution.
My name is Belmiro Parada. I'm a urologist from Coimbra, which is in the center of Portugal. If you don't know it, I think you should visit.
I know. I'm not so good in geography, but I know what Coimbra is. Coimbra is a big university, very, very important.
Yes, it's the land of knowledge in Portugal. I think that I would like to comment on surgery. I think the surgery of metastatic lesions in renal cell cancer has its place. So I think the only thing I would change in the strategy, I wouldn't consider focal treatment up front. I think that a laparoscopic adrenalectomy gave you a lot of information. Pathology of the metastatic lesion. It was well done. Sometimes it is quite difficult, so I think the surgery was quite a good option in this case because it gave you some additional information, and I don't think that focal treatment would be a better option.
That's interesting. However, it's an MDT decision, you see? That MDT does mean that a bunch of people consider also surgery, I think, and they decided. Probably if you're a urologist, you're a surgeon, you're not the only one, and so the decision is not yours.
But I'm not.
Now, this is only a
I'm not
consideration,
criticizing
yeah.
because it's once things are done, it's easy to comment. It's easy for us to comment. I think they are experienced. They are a well-known and experienced
But you
team,
know,
so
this case is very useful for everybody here. You know, because when we go home, we have another experience we have to bring to our practice. Other comments?
Yes.
Yes.
Estevão Lima from Braga, a city from the north of.
Thank you, sir. Thank you, sir, for the explanation.
I agree with Belmiro Parada, but I have another question. Is a question for the oncologist. Why not chemotherapy, the doxorubicin based? Because I know that there are a lot of response in cases of a lot of sarcomatoid.
I don't agree with you. I don't think it's a good option. From what I've reading and from my experience, I don't think.
Because
I don't think
we read a lot.
doxorubicin, it's
There are
So
a lot of papers that
there aren't a lot.
with
There are
a lot
few
of
papers.
component of the sarcomatoid component, there are good response with the doxorubicin.
Yes. So
Chemotherapy
our
based.
college says that in sarcomatoid type or subtype tumors, you know, if you give doxorubicin, the response rate is good. Do you agree on that?
It's like in some cases that are pure spindle or sarcomatoid. No, they can respond, but we don't have an advantage in overall survival. And that's what we want in this patient. So we rather prolong survival with quality of life, or we don't do the strategy. This patient is not going to be cured. So but this patient is asymptomatic. It doesn't need a response. It needs to live more with quality of life. So chemotherapy here, I don't think it's...
May I say something? And another thing is toxicity of adriamycin because doxorubicin. She had already had a cardiac event that we didn't know what it was. Could be a Prinzmetal angina or something like that. And I think it would be risky to do anthracyclines in this patient.
And we know for granted that renal tumor and many other tumors, it's an heterogeneous disease, so we don't know what we are treating. And
Yeah. Okay.
no, we don't know most of the time.
Yeah. Excuse me. We have another comment. Two comments. Derek and then the American guys, get up.
What do they know? My question is about the use of PET in renal cell. It's a lot of variable results. We tend to stay away from that. I wonder if that's led you down an uncertain path here.
I explained the reason why we used PET, because we could not use IV contrast. And we discussed this, and normally we do not use FDG PET in renal cell carcinoma.
Yeah,
we just don't use it.
We
use it because we could not use IV contrast.
Okay, Derek?
I was just going to comment that, one of the great myths of modern medicine is that doxorubicin works in sarcomatoid variant. There's a very high response rate that lasts all of about 6 weeks. So in this context, I completely agree with the decision-making not to use doxorubicin. They're very short-lived responses. They do create toxicity, and as our colleague said, this is a woman who has some cardiac issues anyway, so I wouldn't have touched doxorubicin.
Can conclude that we not use doxo because it doesn't work for a long time. Okay, good. We go on, and histology is very, very interesting.
And
Renal
histology
cell
is not sarcomatoid.
is not sarcomatoid
sarcomatoid.
right now. You know right now. Okay. Then he continued with Nivo. Okay.
But even if it was sarcomatoid, I would definitely change the treatment.
Okay. You have a phone call? No. Okay.
So we had another problem in November 2017. After the surgery, everything went okay with the surgery. She started to be followed by endocrinology, and she had to have specific therapy. She had an asthma exacerbation. She did move a lot, and she had probably she had this problem of asthma more frequently, but she wasn't very active, so we never noticed that. But in November we noticed that. We made a CT scan from the thorax to exclude lung toxicity from nivolumab, and we excluded it. And we saw at this time that the infracarinal adenopathy was stable, and this was confirmed by the PET, which excluded new lung lesions or new lesions, and we had both lesions that we knew, we have them stable. In December, we discussed the case since we are reaching the 2 years, which is probably as good as any other time point, but we thought about stopping therapy at 2 years. And what we decided was try to treat the mediastinal adenopathy, since it was the only site of active disease.
Can I ask you to stop? Do you agree on this treatment? Because, can have toxicity. Not because I see this esophageal prosthesis, but you just do radiotherapy in the intestinal. Does she need it, really?
I don't know if the patient was symptomatic or no, but SBRT in this location seems a little bit disproportional to the systemic disease that this patient has. And additionally, perhaps this is the only disease of all the approved indications of nivolumab that we can have really a benefit of treating after progression. There's an analysis of the O25 by Escudier that's the patients who did respond initially that are clinically asymptomatic and can do the therapy without toxicity seem to have an overall survival benefit with nivolumab. So I would probably continue nivolumab and only do radiotherapy if she really needed symptomatic relief, not SBRT.
Do you agree on that?
Well, stopping nivolumab at 2 years, it's a case of discussion. The data are not clear about it, and the magic number 2 years, it's really, what should I say? It's really not a defined mark.
Any comment from the floor? Yes, one comment from urologist. Surgery? No.
First of all, I would like to say that the patient is very lucky because he's treated in a very good place. So let's put it clear. I think that perhaps the purpose, and Nuno Val can answer on that, I think that the purpose was to try perhaps a curative approach, because that's the justification to treat the lesion from the mediastinum. Otherwise, I think that would not be the case. Perhaps, I don't know, perhaps you consider that it was the only lesion, and we know that in renal cell cancer with metastasis, sometimes you achieve long-term remissions with...
Yeah. That was the rationale. We know from renal cell carcinoma that if we are aggressive in treating a few sites of disease or one site of disease, we might have some impact on overall survival.
I would like also to say that I would also keep a close eye on the renal lesion, because the Bosniak 4 lesion has a chance over 50% to be a malignant lesion. So
I think the two important issues here. One is the stopping or not NIVO. This one. The second one is what happened to the kidney with the lesion of the kidney.
Well, I became a little bit, not confused, I just didn't hear. The adrenal metastasis that was removed, is this from the second primary in the kidney, or is it a metastatic from the kidney that you removed 2 years ago? It's not completely clear. The patient has a lesion in the kidney that's there, that's adjacent to adrenal, and what was the histology of the adrenal?
I don't think you can define it.
Clear cell.
Clear cell.
Renal cell carcinoma.
Yeah. Any other comment? Okay, this is the last one, I think.
Yeah, this is the last
Okay.
one.
January. Go on. We stopped NIVO.
So we stopped NIVO. We prepared her for the mediastinal radiotherapy. She already had the prostheses in place, and we are awaiting to the radiotherapy. And we consider repeating the PET and the MRI to see the kidney lesion evolution in 3 months after the radiotherapy.
Okay. Any comment? Any other? Yeah.
I would just like to ask one question.
I'm sorry, I'm a
Sorry.
radiation oncologist.
Oh.
I think I would like to say something about this SBR.
Excuse me, I didn't
I'm
see
Paulo
you.
Costa. I'm from Porto and also Braga, here near in the north of the country. And I think it's important to understand. I really don't understand what's this kind of SBRT to mediastinum. And if you extrapolate from lung cancer, and this is an ultracentral location, and the toxicity which is achieved with ultracentral location in lung cancer, it's very high. So the RTOG trials, they are telling us of grade 5, level 5 toxicity, which is death, okay? So I don't really understand what this SBRT,
I'm not the proper person
I wouldn't
to ask
perform
you
it,
to
and I
answer
work
you.
with a cyber knife, so I don't really understand what this SBRT is going to be, so I would like to understand
Paul,
it.
But still,
I'm
it's
not-
been decided during the MDT.
Well, MDT, it's not a holy grail.
I-
I have my own head to think about it, okay?
Okay.
So I'd like to understand.
But I
what-
understand what you. No, it's important. They did. I mean, brainstorming, just discussing as we do, and this was the decision. Personally, I agree with you. I would never take into consideration radiotherapy in this case because of toxicity, possible toxicity. However, they already prepared the lady with the prosthesis in the esophagus. So they already.
I'm sorry, it's not the esophagus toxicity that I'm scared about. It's about cardiac toxicity and arterial toxicity. That's the main problem here, okay?
Okay.
That's what the RTOG trial has told us before. So,
Yes, so
and
you
it's
can
in lung
stop.
cancer.
You can stop the SBRT.
No, next time I'll bring a radiotherapy to you, because if he asks me about lymphoma,
Okay, you
I
have
could
to
ask
argue.
him. But asking me about, but he knows the names
But
of the colleagues, he can ask them
I really
directly.
think that this case is helpful also for the presenter, because you go
Because
home and they say,
What I know and I take for granted
Yeah.
is that a few number of foci, or one foci in renal cell carcinoma is to be treated, either with surgery or with radiotherapy. I don't know. It depends on the discussion.
So you're
I
convinced?
myself, I would prefer to have radiotherapy than to have a cut, to be put to sleep, and all of that, myself.
Okay.
Because the local control probably is not different. We miss something with radiotherapy, you don't have information about histology, whatever. I agree.
Okay.
But at this point, what I know as an oncologist is I feel more comfortable having this lesion treated.
Okay. Any comment?
If it is treated one way or
I
the
think
other.
any final comment, Derek? And final comment. You gonna close the day.
Well, I'm known internationally as being very conservative, and so I would ask one question. I don't disagree, or in fact I agree with the radiotherapist from the north who said you can do a lot of damage with SBRT, and I understand your colleague told you it would be okay. But there is one other option that's not unreasonable, which is in this context, what would you lose at this point by just stopping for a couple of months, repeating the PET scan, get a sense of the pace of the disease. Because if you have 5 new lesions, you're completely wasting her time having SBRT. So I think I would go back to your home base and say, I heard someone who said, what's the rush? This has gone a very long time. Everything has been very slow. We often, particularly medical oncologists, love to treat lesions that aren't moving, and we then say that we have stable disease. So I would put to you the thought that you wait a couple of months, reassess in a couple of months, let her get over the NEVO, and then you can reconsider the whole thing, see what the pattern of disease is. She's had a bit of a immuno-rest, and then you take it from there.
No, you have to organize an MDT when you go home. You have to organize an MDT when you go again. And I think it's very logical what Derek says. I mean, we should. But I'd like to thank everybody for this nice discussion. I mean, everybody was involved. This was what I wanted to do. And thank you very much. Have a good night.
Thank you.